Fergus Couch. I'm from the Mayo Clinic. I study genetics of cancer, mainly breast cancer, pancreatic cancer. Our main work is to identify the genes that cause the cancers and then work out the risks so that we can give personalized risk estimates to the different patients. In other words, right now we give everybody the same essential risk if they have a mutation, but we know that some people are at higher risk, some people are at lower risk. If we can work that out in detail, we can then go back to each individual patient and give them their own risk. So there are certain genes that seem to drive cancer. We think of mainly genes involved in DNA repair process in cells. We don't really know why they only cause certain cancers, but the ones we're most familiar with are the BRCA1 and BRCA2 genes that cause breast cancer, ovarian cancer, and now they've been implicated in endometrial cancer and pancreatic cancer. But they don't really seem to have a role in many other cancers, such as melanomas, kidney cancers, liver cancers, and other diseases like that. There are other DNA repair genes, a different type of DNA repair gene called mismatch repair genes that also cause colorectal cancer. They've been implicated in ovarian and endometrial cancer as well. So it's really unknown at this point why they only affect certain tissues in the body and why they only cause certain types of cancer. But again, our goal is to really try to understand that and understand the risks for the individual patients. Beyond BRCA1 and BRCA2, there are panels of genes that people screen now looking for germline mutations in predisposition genes. Most of these panels are about 25 genes in size. And some of the work we've been doing, screening hundreds of thousands of patients looking for mutations in these genes, are allowing us to recognize that some of these genes are not really breast cancer or other cancer predisposition genes at all, and really should not be screened. So in the near future, I think we'll see some of those panels getting smaller. Now, in addition to that, there are other types of genetic changes that are very common. Maybe 30–40% of the people walking around on the street have some of these. In fact, have every one of these. And so we can look at those and put them all together. And right now, there are about 175 of these markers that are known for breast cancer. And each one is a very, very small amount of risk, so it's of no clinical value at all. But when we put them all together into a combined model, we now find that there are actually quite strong risk factors for breast cancer, up there with the number of children that a woman would have, or diet, obesity, some of these well-known risk factors for breast cancer. So there's a lot of work going on currently to integrate that information, all these common genetic factors with the rare factors and with other risk factors, to try and again personalize risk for the individual woman. We have been interested in figuring out which of the genes on these cancer risk panels are really important. Right now, there's a lot of information in various manuscripts that suggests that they have a role in breast cancer, but we want to know more. We really want to know what the levels of risk are for each gene. It turns out we really don't know that. And one way to figure that out is to look in the general population and collect very, very large numbers of individuals and test them for mutations. But that's extraordinarily expensive. Right now in the United States, a panel screen would cost you $4,000 for one patient. So for researchers to be able to do these types of things, we needed an alternative strategy. We needed a high throughput strategy and a cheap strategy. So we teamed up with QIAGEN, and QIAGEN has the new QIAseq version 3 methodology, and we have adapted that to our high throughput work. We've automated it, roboticized it, and come up with algorithms for analyzing very large numbers of samples at the same time. So we are actually currently running 800 patients a week in batch mode and analyzing them across 38 different genes. And that's all with the help of the QIAseq panel. And we probably could not have done it without the interaction with the company. In the near term, this will be a complementary strategy. We will be combining the liquid biopsies with physical biopsies, maybe reducing the number of biopsies that a patient would have, but certainly it won't completely replace the physical needle-based biopsies that many patients undergo today. However, as we go forward and the technology improves and we really understand how to better recognize the cancers, it may be that in time we can get to that, but not in the next couple of years. I don't imagine that that would be the case. Liquid biopsies are interesting. There's really two ways of using liquid biopsies. One is to track the cancer after it's already occurred and determine whether the tumor is shrinking in response to therapy, whether the tumor is coming back. It's very effective in that way. It's actually more difficult in the other way, which is to predict the presence of the cancer before any symptoms are present. And there are a number of companies now trying to do this. Can they go early into the bloodstream of the patient, of the individuals who don't yet have cancer, and actually detect early cancers, which of course would dramatically improve survival rates from some of these diseases. So as I was saying, there's two different ways to approach liquid biopsies, and many companies are doing this. And again, we are trying to work with QIAGEN right now to evaluate the use of the QIAseq panels and to adapt it for liquid biopsies in the early diagnostic space. It's likely going to be a combination of all of those things. None of these techniques alone will be sufficiently sensitive to detect these early cancers. In terms of tracking tumors, I think the DNA biopsy is fine, just tracking the performance of the tumors, because in that case, you often know the mutations in the individual's tumor already, and you can just track those specific mutations quite easily. In the early diagnostic space, in the pre-diagnostic space, you don't know what's in the mutation in the tumor because you haven't found the tumor yet. So you have to scan a broad range of genes. That becomes very expensive. So again, I think we need the exosome RNAs, we need microRNAs, we need DNA, probably all combined together into complex assays to detect the early cancers.